Hello, this is Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club. This week we have a great episode for you. It's in our usual format, featuring some fascinating papers, some quirky quick bites, and an MBS update. Hans also interviews Professor Georgina Long on a recent publication in Nature Medicine on pathological response and survival with neoadjuvant therapy in melanoma. It's a very passionate and engaging interview, so this is a must listen to. I hope you enjoy today's entertaining and informative episode. As ever, links to all of the papers discussed today are available in the notes on our website, oncologynews.com.au. And if you'd like to be notified when new podcast episodes are released and to receive free news updates every week covering all the latest breaking oncology news and a few quirky articles too, then why not sign up to our weekly publication, the Oncology Newsletter? You'll see a link on oncologynews.com.au and it's free. This is Rachel Babin and this is the Oncology Podcast.
G'day, g'day, g'day. It's the gang at the OJC back for another normal episode. Craig, how can we have a normal episode with you in it?
Well, hello, Miss Eva.
You're getting very musical, Craig, ever since your debut on World Lung, episode 1.
Enough of that, I think. No, enough singing and rapping. How are you, Eva?
No, I'm good. I'm great. Excited to be back because lots of good stuff on today's podcast. And our very good friend, Hans Brennan, is going to kick it off. Hans, I hear you've been seeking the company of other Australian women recently. Here's Hans talking to our one and only, the very wonderful Professor Georgina Long, about her latest publication, Changing the Landscape with Neoadjuvant Therapy in Metastatic Melanoma. Take it away, Hans.
So it's my pleasure to have a guest here in this podcast. It's Professor Georgina Long. She's co-medical director of the Melanoma Institute Australia in Sydney. And she's here because we selected her most recent paper, which was published in Nature Medicine. So Georgina, welcome to this podcast. And would you maybe tell us very briefly what the main findings were of this study in Nature Medicine?
Sure. Thank you so much for having me, Hans. It's actually very exciting. The major findings are that neoadjuvant therapy in melanoma, whether it be immunotherapy or BRAF targeted therapy, and as you know, and the audience would know, they're the two major treatments we use in melanoma drug therapies. But when given neoadjuvantly in stage 3 resectable melanoma with measurable lymph nodes, we see that complete pathological response correlates beautifully with relapse-free survival with either of those therapies. So that's the first thing we show, which is really, really critical because we would like to use that neoadjuvant platform to test novel combinations. So now that we've established that complete pathological response correlates beautifully with relapse-free survival versus no pathological response or any other type of pathological response, we can now use this as a platform for novel drug therapies. So that's number one. Number 2, which was really exciting. May I talk about number 2, or did you want to ask me about number 1 first?
Maybe I had a question about number 1, because as you know, I'm a GI oncologist, so I'm not an expert in melanoma. But if you ask me, it's not a complete surprise. If you see a lot of GI tumors, we see this in rectal cancer. We're already doing this for 20 years, giving neoadjuvant. You see this in a lot of other tumor types like gastric cancer. So why is it still surprising to you that complete pathological response is some kind of surrogate marker for a good outcome?
So it wasn't a complete surprise, but this is the first time we've shown that in melanoma. That's the first thing. The second thing, and this comes to my second point I was just about to make, which is why I'm glad this is a great segue, is that immunotherapy specifically. So in this pooled analysis, it was a pooled analysis from 6 clinical trials. There were 192 patients. 141 were treated with immunotherapy and 51 with BRAF targeted therapy. And when we pooled it all, as I just said, complete pathological response correlated beautifully with relapse-free survival. Now I'm going to delve into just the immunotherapy patients. And this is the first analysis of any neoadjuvant immunotherapy in the world for any cancer. And what we found was that if you had any pathological response with immunotherapy, whether it be complete, whether it be near complete, which we've defined in a previous paper published in Annals of Oncology in 2018, that was actually led by Michael Tetzlaff and Richard Scollier. But by analyzing the pathological responses complete, near complete, or partial pathological response, which is 50% of tumor cells or less present, they basically did the same. And these patients virtually never recurred. So it wasn't just that they had an improved relapse-free survival. We actually saw a flatlining of the relapse-free survival. That has never been seen in cancer before. And what's so more exciting about that flatlining is that you can actually feed back to patients. So you can say, hey, you've had a pathological response. Doesn't matter whether it's complete, near complete, or partial on your immunotherapy. We can say you've got a very low risk of recurrence. It's less than 3% for dual ipilimumab PD-1 therapy, CTLA-4 PD-1 therapy, less than 3% recurrence rate. To compare it to stage 3 normally, even in the adjuvant setting, we see recurrences in up to 50% of patients for stage 3 as a whole. But if you take the bulky lymph nodes, which is what we've done neoadjuvant therapy in, we see recurrences in 60 to 70% of patients. So that was the exciting part of this paper. It was actually the immunotherapy part, which was just stunning. And what's more, when you use dual neoadjuvant immunotherapy, 2 doses, only 6 weeks worth, 75% of patients had a pathological response.
Would you say that BRAF targeted therapy, is it then a bit different than immunotherapy? So the results are better with immunotherapy?
Absolutely. So what we did is, after we showed that complete pathological response correlates beautifully with relapse-free survival, we then dived into just immunotherapy and targeted therapy. Now, remember, it's a pooled analysis, so it's not like it's a randomized study and you can compare them directly, but you can sort of imply or implicate what's going on biologically by looking at the curves. So for immunotherapy, any sort of pathological response, 50% or more tumor death in the tumor bed, excellent long-term survival. And for dual immunotherapy, 75% of patients had a pathological response. So that's unbelievable. For targeted therapy, very different. So for complete pathological responders, we saw they did great in terms of their relapse-free survival. However, we still saw recurrences with those complete pathological responders with targeted therapy. And partial or near complete really behaved the same as no pathological response for targeted therapy.
And maybe from a mechanistic point of view, because maybe you're aware of the Nature Medicine publication of about, I think, 20 colon cancer patients where they gave neoadjuvant immune therapy. And normally it only works in MSI colon cancers. But in this case, a few of the MSS also responded. So my question to you is, do you think that immune therapy might work differently in the neoadjuvant setting than it works, let's say, in the metastatic setting?
So that's a really good comparison. So I think there are several things with your question. Great question. So we've got the adjuvant setting, which we use routinely with colorectal cancer. Not colorectal, with melanoma. We've got the neoadjuvant in melanoma now, and we've got the metastatic setting. So to compare the metastatic with the neoadjuvant, it's a little tricky. But yes, I do believe we've got, it might be a volume, a cancer volume thing, in that you've got enough cancer on board to mount a really effective immune response, but not so much cancer involved or really bad biology where the cancer spread around the body, stage 4, where you have some immunosuppressive effects or microenvironment effects of having metastatic disease. So, for example, we know that LDH high in metastatic melanoma patients, that does exert an immunosuppressive effect. Now it's the chicken or the egg. Is it the biology? Is it the LDH itself? It's a bit of both, we think. What I find more interesting, though, as a comparison, is comparing neoadjuvant with adjuvant. And we did do a pilot. In fact, in Netherlands, they did a pilot study of neoadjuvant versus adjuvant, exactly the same dual immunotherapy, either before or just given after 4 cycles in that study. And what they found was that the T cell clones expanded much more effectively. So existing T cell clones expanded much more effectively in the neoadjuvant setting compared with the adjuvant setting. So there is a biological rationale as to why neoadjuvant would be better than adjuvant in terms of mounting an immune response. But your other comparison that you specifically asked about, neoadjuvant versus metastatic, we don't know why, but certainly the results point to neoadjuvant having a slightly more effective immune reaction against the cancer. And it could be that you're selecting out the slightly better biology patients because, of course, stage 4 will include that 20% of really bad biology where they just trundle through primary melanoma, lymph nodes straight onto metastatic disease. And so it's a bit hard to tease that out at this point, but we're working on that.
So if I hear you speak, you're so enthusiastic about the results, which I completely understand. So you completely convinced me. But is this then the new standard from, let's say, tomorrow onwards? So why would you not do it?
Not yet. Look, it's a good question. And we have that question every time we see stunning results in cancer. We think, wow. But the truth is we are obliged to do the proper randomised controlled trial, scientific method, and test this hypothesis in a proper way. So we are embarking on that. In fact, we've written the protocol and we have a planned study of combination immunotherapy, anti-PD-1, anti-CTLA-4, 2 doses prior to surgery, followed by observation if you have any pathological response. If you have no pathological response, which is about 25% of patients, you then have your adjuvant therapy to a total of 12 months versus current standard of care for stage 3 melanoma, which is resection first, then 12 months of adjuvant anti-PD-1 therapy. So we've written the protocol. I've just written a grant to fund it in Australia, across Australia. My colleagues at EORTC and at Netherlands now looking at doing that in Europe. In fact, I'm co-leading this with Christian Blank, who is a real champion in the Netherlands. We're pushing forward with neoadjuvant therapies. I think they're set, ready to go. And so we want to get started on that trial as soon as we can this year. Then it'll become standard.
Yeah. So, Craig, do you still have a question?
Georgina, it's a really exciting field. We're seeing, neoadjuvant really being tested in a number of tumours, as you just touched on. I think we have a lot of trainees that listen to the podcast, and some of them may not sort of realise the rapid advances we've seen in recent years, and certainly in my working life, it's just incredible. So if we look forward, where do you think we're going to go next? So we're seeing these plateaus on the curves of the melanoma metastatic disease, and we want to obviously push that plateau up. So what do you think is going to drive the next change? Is it going to be, different immunotherapy drugs or?
Good question. I think there will be a future and we will push that curve up. That's the first thing to say. The focus we have in melanoma and across the field is looking mechanistically at primary resistance. So we spend a lot of time curating the patient data and our patient samples to look very specifically at primary resistance, because that is the golden chalice, so to speak, probably not just for melanoma, but for all cancers. Acquired resistance or, other clinical matters are important, but our greatest concern in terms of trying to push that curve up is really if we can focus in on those patients, we will understand more. So then it's looking at the mechanisms of resistance so that we can then come up with therapies that target it. One thing I think we've got to get right is what we're doing in the lab where the scientists and the clinicians meet. And it's not bulk analyses of responders versus non-responders anymore, of RNA-seq of both those groups, and let's see what is different. It's got to be a lot more thought out and planned, and it also requires really close collaboration with your clinician to understand the specific kinetics of that specific patient and that specific tumor, because we already know, in fact, this hasn't been published, but we've got a manuscript in preparation and others have shown this, that resistance, primary resistance with immunotherapy is extremely heterogeneous, just like everything else in cancer. So I think pushing that curve up, we may not see those big bounds up as we did with PD-1 and CTLA-4. We will be looking at specific resistance that are done on a curated single patient level, not big bulk analyses, to understand how we may be able to alter the specific tumor type, the resistance. I think there will be groups of patients who have similar mechanisms of resistance, but I think we will have lots of groups of different patients. So, for example, more recently, we showed that a VEGF inhibition combined with some receptor tyrosine kinase inhibition combined with PD-1 can be effective in even primary resistance of CTLA and anti-PD-1. That's not for everyone. That's about 20% of patients. And so this, with the clinics actually ahead of the lab. So working out what those groups of patients are and why is our next hurdle. And I think we'll get there. I also think that we can do, there's exciting things happening with CAR T cells, which have been around for a while now, actually, a good decade, that we can get smarter with. And as well as that, even TILS therapy, good old-fashioned TILS therapy, I think we can enhance and get better at. Now that we have this broad cancer interest in immunotherapy, because I can tell you 15 years ago, us melanoma doctors were alone with immunotherapy. And so now that there's this real belief that this can work if we can get the hook right, I think we can alter the way we do TILS therapy to be a little more specific with certain subset of patients. So overall, I can't give you the golden chalice answer. I wish I could. I'd be a billionaire if I could. But I think it's the approach that we now must take. And it can't be bulk. It's got to be very specific and drilled down to an individual patient level in the lab first, and then we'll hopefully get that into the clinic.
So it sounds like from what you're saying, it's about maybe a changing paradigm in how we conduct trials, and it's ensuring that we have a platform in place for that translational interaction and ensuring we have a platform in place for all patients to really be able to access the clinical trials. So there's a lot to do. It's very exciting though, isn't it?
Yeah, it's a very exciting. There was one other thing I was going to say. So besides relying on the lab to help us, but the other thing is earlier stage disease. I think we're going to head into a period now where drug therapy gets used earlier and earlier and earlier. And the role of the surgeon and the local therapists, I'll call them, radiation or surgery, is going to change. They'll be very important because especially the surgeons, that's where we're going to get the tumor to actually test what to do with patients. But I think that role will change, and we may cure, let's say, more people by looking at what we can do earlier in the course of their cancer with drug therapy. So that's another era I think we're entering now.
Thank you, Georgina, for this incredible interview. I learned so much today, and I hope Craig did as well. So very pleased to have you here, and let's hope you come again in our show in the near future. Thanks, Georgina.
Yeah, thanks so much, Georgina. Great to have you on.
Well, thanks so much, Craig, and thanks, Hans, for having me.
So, Craig, you better try and beat that one. What have you got for us?
Well, I picked what I think is an interesting paper, Eva, from JAMA Oncology, 25th of February, and it's called An Assessment of the Clinical Benefit of Integrative Genomic Profiling in Advanced Solid Tumours. So this was an interesting study looking at whether the use of next-generation sequencing to identify actionable genomic targets incorporated into routine clinical practice for the management of solid tumours would actually demonstrate some clinical utility, because that remains an open question. So it was to determine which patients derived the greatest degree of clinical benefit from NGS profiling. So this was a study in quite a big cohort of patients, 1,138. They all had a fresh tumour biopsy and blood sample collected for genomic profiling, looking at the tumour and normal DNA and the tumour transcriptome RNA sequencing. And this was done it was over a long period of time, 2011 to 2018, and analysed from 2011 to 2020. So they also looked at the patient's therapy and treatment response and extracted that from the medical record to determine the clinical benefit rate from NGS-directed therapy at 6 months and in looking for exceptional responses lasting 12 months or longer. So 1,100 patients, they found actionable genomic alterations in 817 patients, or 80%. Of these, 16% received sequencing-directed therapy, 49 had clinical benefit, so 37% of those who received the sequencing-directed therapy. They saw exceptional responses, so that was, as I said, defined of lasting 12 months or longer, in 26% of patients, or 19% of those treated. Pathogenic germline variants were identified in 160 patients, including 49 of therapeutic relevance. So they actually found some patients with tumours with BRCA mutations or other mutations that made them susceptible to PARP inhibitors. So in fact, it was in this group of patients where they saw the most exceptional responses. So an interesting discussion about the utility of using this kind of test. Of course, cost remains an issue, but as cost gets driven down for the NGS profiling, I'm hoping that we'll see more and more patients having their tumours tested and hopefully having mutation-directed therapy and deriving some benefit. So it really highlights the need for a change in paradigm in the way in which we classify tumours, look at the ways to manage them, and list drugs to make them available not on the basis of tumour but tumour agnostic listing, so that we can access drugs where a rare mutation is found in an individual patient. So more sort of evidence that this is the way I think oncology will be heading as a field in the years ahead. So click on the link if you want to see some more information.
Thanks, Craig. Of course, it's oncology, never as simple as it seems. So some of these tumour agnostic mutation therapies work equally well in different tumours, but others don't. Look at BRAF and colon and melanoma. So there is a need for a tumour board to interpret the results, and goodness knows how many MDTs we can go to in a week. I guess a lot by Zoom, but definitely the molecular MDT is the way of the future.
Yeah, that's right. And so apart from PARP inhibitors, there was also some patients that were found to have HER2 mutations or overexpression. Of course, we've seen new molecules presented at international meetings recently with new anti-HER2 agents, and the old ones, Herceptin, of course, now off patent and less expensive. So, there's some argument that we should be doing testing of some relatively common mutations if we can, where we have patients that have no other effective therapy.
Yes, and interesting again that unlike in breast cancer where predominantly you have HER2 overexpression, in GI cancers, for example, mutations account for a significant number of abnormalities. So again, subtle differences, but molecular classification is the key.
Yeah, so a really interesting field. So Eva, I know your paper is also very interesting in this episode. So tell us, what did you bring along?
So I'm bringing a series of articles that I'll summarise, and they're called Recommendations of the ASCO Friends of Cancer. And it's a series of different multi-stakeholder working groups that have been going for about the last 4 years. And they're based on the theme of what's called modernising clinical trial eligibility criteria. So in JCO 2017, they published a research statement entitled Broadening Eligibility Criteria to Make Clinical Trials More Representative. ASCO and Friends of Cancer Research joint research statement. And over the years, various working groups have given recommendations. For example, in 2018, the HIV working group gave a recommendation that really patients shouldn't be excluded from trials just on the basis of HIV if they've got very well-controlled disease and no viral load detected. So this year in the journal Cancer Research, 4 of the groups published their recommendation. One was the prior therapies group, and what they said was, we shouldn't be excluding patients on the basis of lines of therapy unless there's a really good rationale for that drug, like that previous line of therapy might have induced a particular mutation, say with the EGFR mutated lung cancers. But they said a lot of times we're limiting the drugs to specific lines of therapy without really a rationalisation. The second working group and publication is the washout period and concomitant medication work group. And they said that the exclusion criteria based on washout periods, for example, you have to be a month since your radiotherapy or a certain time after previous treatment, they said they're inconsistent. And again, they lack scientific rationale. And the paper goes through where there really is a rationale for waiting and points out those scenarios and says the rest really, we should not have this as an eligibility criteria. The third one was also very interesting. It was the laboratory reference ranges and testing intervals. And what they did was look at clinical trial eligibility criteria and showed that over time, really, there's been very little change. So we all know the poor patient who can't get on because their creatinine clearance is slightly below the trial-defined criteria. And again, they say it's not really sensible. This is just historical expediency, but it's causing a lot of patients to miss out on trials. And the final one was the performance status working group. And what they did was ran a simulation trial. They looked at a number of ECOG2 patients. And they said even if you have small number, even if the PS2 patients don't derive a benefit, it's worth having them in on the trial. So their conclusion was expanding performance status eligibility to be more inclusive and more representative of real-world patients because, we write ECOG 1 to 2 when they're 1.999.
Oh, you've never done that either, have you?
1.98. They usually ECOG 2, but today they're ECOG 1. They got a good sleep. So anyway, all of these articles then culminate in a perspective piece that summarises really that unless we change some of or all of these things, we're going to continue to have a very low rate of eligibility for clinical trials. And we really need to change the paradigm. Liver function is a constant bugbear for those of us in GI trials with liver metastases. You've got drugs that aren't being metabolized through the liver, and yet there are these limitations. And Craig, once again, congratulations on your incredibly successful grant for your regional trials network. I'm sure we'd be interested in hearing your comments as the head of that network and that huge grant project. Do you think this would allow more regional and rural patients on trials?
Well, yes, definitely, Eva. I guess we're lucky in a lot of the regional centres. We actually do have sort of good, normal, inverted commas, oncology patients that don't have the comorbidities that often exclude them, that you see more in the tertiary or quaternary centres. So, we've actually got a pretty good track record of when we have trials available that we can recruit well. But look, I think this is no one would disagree at all with you picking this paper and the intent. It's where do we go to now as an industry? How do we advocate for the change through our MRFF grant, where one of the programs is registry trials? So this is perhaps an opportunity where we can look at broad eligibility and run some registry trials, which for those who don't know, they're fairly simple trials, simple in the administration and the collection of data, designed to answer real-world questions like, is listed drug A better than listed drug B? There's a 2-page case record form to fill out rather than hundreds of pages. The eligibility criteria are real-world. And I think maybe we need to look at using this approach in the design of some of the registry trials through this program and others. So it'd be interesting to see what others, key opinion leaders like yourself and others, think, Eva, about where we go to. I think the cooperative groups obviously need to tackle this as well. I think, again, we've had the 2 papers here about changing paradigms that we need to think about probably.
The Dutch are real leaders they actually do randomised controlled trials, and they don't need to recruit to the randomised arm because they have a registry, a population-based registry that people, I think, have to opt out of. So they basically have a comprehensive registry, and that acts as the placebo control or the standard therapy for their trials. So that's something towards astonishing.
Are we reinventing wheels here in cancer? Like, are other fields already doing things like this that we could learn from? That's the other sort of thought I had as you were discussing it.
Yeah, absolutely. And also comparing new agents, same class, like the next PD-1 inhibitor and the one after that and the one after that. Much easier to, as you say, compare drug A and B using a registry trial than to do a huge non-inferiority randomised phase 3. So, great papers this week. I'm looking forward to your quick bites, Craig.
Yeah, so I've got 3 to do, Eva. So the first one is from the JCO. It's called Therapy for Stage 4 Non-Small Cell Lung Cancer with Driver Alterations, ASCO and OH Joint Guideline Update. So it was written by sort of a who's who in lung cancer oncology, and it's updating the 2017 ASCO guidelines using randomized controlled trials presented between 2015 and 2020. And also, interestingly, they added evidence from the meeting abstracts from ASCO in 2020. So 27 randomized clinical trials, 26 observational studies, and 1 meta-analysis updating the previous guidelines. For the first time, to the author's knowledge, the guideline included recommendations for RET, MET, and NTRK alterations, and pointed out that there's now targeted therapies against ROS1 fusions, BRAF V600E mutations, RET mutations, MET exon 14 skipping mutations, and the NTRK. So again, reiterating the importance that all patients with advanced lung cancer, regardless of the smoking status recommendations, when possible, should have next generation sequencing or IHC screening for mutations in their biopsy to look for these rare but important targets with available treatments against those. So first time recommending osimertinib as optimal first-line treatment for patients with EGFR mutations, and also alectinib and brigatinib as alternatives for optimal first-line treatment for anaplastic lymphoma kinase MIF fusions or ALK fusions. So a sort of important guideline paper.
You're on the theme tonight, Craig. Go on.
I am. And then a review. I won't go over the details, but this is I just wanted to impress you that I'd read this journal, even the Nature Reviews Clinical Oncology, Unlocking the Potential of Antibody Drug Conjugates for Cancer Therapy. So there's a lot of interest in this new class of compounds. The hematologists have been using gemtuzumab ozogamicin and brentuximab vedotin for some time. And, of course, we've had trastuzumab emtansine, or TDM1, in breast cancer. But this paper also talks about some new molecules. We've looked at these in international presentations recently on the podcast. So we've got trastuzumab deruxtecan, sacituzumab govitecan, and enfortumab vedotin. So I've just been practicing those pronunciations. Happy with those. So have a look.
Very good.
These are all molecules that have a payload that's delivered by the antibody. Just talks about the mechanism of action and potential uses in the future.
Yeah, it's fantastic. And the day we can link that through to molecular imaging as well will be amazing. Great paper. Yep, highly recommended. And for the last one?
It's an editorial from the Lancet Oncology, World Cancer Declaration, time to consolidate wins and work towards 2025. So it's looking at in 2011, they published the World Cancer Declaration. You can click on the link to see that. And it's looking at how, with just 4 years to go, how we're going. Overall, there's been considerable progress. 95% of countries now have a Ministry of Health unit responsible for non-communicable diseases such as cancer. 87% of patients in a 15,000 people survey in 20 countries could name at least one risk factor for cancer, and 3 in 5 reported being concerned about developing cancer in the future. But some noticeable problems still, and we've talked about this on the podcast in the past. 2 things. One is a lack of access to palliative care and simple opiates in many countries still, which is a bit of a tragedy really. And also some warnings about the expected disruption of the COVID-19 pandemic towards those targets in 2025. So it's of general interest for oncologists to have a look at that. And lastly, Eva, very quick, I've got an MBS update. So interestingly, in Australia, they've changed the wording around operating on prostate cancer. So it's now a requirement that patients should be offered sequential consultations with the surgeon and a radiation oncologist before undergoing a radical prostatectomy. So again, a changing paradigm, and I'd love to get some of the advocates on the show to talk about this and maybe have a debate down the track.
Does it stipulate the order? Surgeon first and then rad-onc? And let's do a randomised trial. The 2 different orders and what the outcome is. Because I reckon they made up their mind by the time they walk out of the surgeons. They've paid the deposit on the operation.
So let's hear about your quick bites.
Well, on the theme that you've brought up of what we're achieving in global oncology towards our goal, there was an interesting paper also in JAMA Oncology, an analysis of contemporary oncology randomized clinical trials from low and middle income versus high income countries. So the question asked was, to what extent do our current trial portfolios reflect the global cancer burden? They did a systematic review-based cohort study, 694 phase 3 RCTs published from 2014 to 17. And no surprise, most trials are conducted predominantly in high-income countries, and they study cancers that do not match the global burden of disease. So RCTs from low, middle, and upper middle income countries are actually more likely, they say, to study new treatments that benefit patients, but they're published in journals with lower impact factors. So I think the big challenge in the next 5 years is this question of global oncology. Feeds into the disparity discussion that's out there in all aspects of life, not just oncology, gaining momentum.
Yes, and this is a good point to mention our episode on disparity, Eva. It was episode 22, and we'll make sure we include a link in the notes.
Now, come on, Eva, you must have something a bit quirky to tell us. I'll be disappointed if you don't.
No, I'm not making any comment, except Twitter's been amazing lately, hasn't it? Did you see Dr. Glaukenfecker doing the first day with general surgery? I was rolling on the floor with that one.
He's so funny. He is our... No, we did him last time.
We did do him last time, but if you haven't got on to him, please do yourself a favour.
I'm going to call Dr. Steve Martin our Twitter account of the week. He's hilarious as well. So we'll put his handle on there for people to follow. If you don't follow him already, please do. So come on, Eva, what's your last paper?
So I've got a couple. One's called Interpreting Bibliometric Data. Click on the link for those who want to know how all these citations and impact factors and that are used and how they could be used in a better way. Do have an interesting negative trial. And I really ummed and ahed about whether to put this in. But in the interest of academia, I think we've got to present negative trials. So this was published in the Journal of the National Cancer Institute recently. The effect of early palliative care on quality of life of advanced head and neck cancer patients, a phase 3 trial. So they took adult patients with SCC of the head and neck who were planned for palliative systemic therapy, randomised 1-to-1 to standard treatment or that with a comprehensive palliative care, early palliative care service referral. And they measured them with the Edmonton Symptom Assessment Scale and the FACT Head and Neck Index. And they measured baseline every month for 3 months. And their primary endpoint was a change in quality of life measured at 3 months. Now, they had 90 patients on each arm, and basically they showed no statistical significant difference in any of the measures. There was no difference in survival between the two arms, no difference in hospital deaths. So why did this trial fail to show an impact of early palliative care where many other trials, including the landmark Temmel paper, showed a significant impact? Is it that these patients really get very close attention to symptoms anyway from oncology? Is it that the disease is just so awful that the early palliative care isn't impacting survival? Have you got any theories, Craig?
No, I don't need to look at the detail in the paper, Eva, but yeah, it was, I guess, counterintuitive to what we've seen before, but maybe it's in the interesting to know when it was done. Is it in the modern era where our supportive care is better, access to cancer navigators, care coordinators is better, so that may abrogate what I think was the benefit of the early referral to palliative care was about case management and addressing symptoms to enable people to stay on treatment for longer. So is it that the system's improved and it's no longer required like it was 10 years ago?
Well, that's possible, although I would argue in certain centres we aren't at that level of care coordination, so maybe we should repeat the trial. So we come to the end of another OJC episode, and Craig, I have great fun doing this, and I learn a lot.
Me too, and I just feel like, I'm learning a lot. Hopefully our audience is learning a lot. It certainly makes you try and keep up with the journals, and it's a fun way of doing it and accessible. So I agree. Let's just keep doing it.
Okay, it's a deal. But seriously, it's so interesting covering the breadth of papers, not just the different tumour streams, but things like global oncology, implementation research, prevention. I mean, you really need to have that broad perspective just to put everything you do in a daily life in context. And on that note, have a listen to our Women in Oncology special that came out with International Women's Day. Rachel Reichelman, she's a superstar, runs one of the largest cancer centres in Brazil as a young woman, and her story is really, I find, fascinating. She's a lovely person. So on that note, lovely people, goodbye, hands. And goodbye, Craig. Thank you, Rachel and Graham. Graham's been a bit sick, so we wish him all the best. And we'll see you next time on Oncology Journal Club podcast. Bye.
See you, Miss Eva.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.